I'm Karim Al-Azizi, interventional cardiologist and structural heart disease specialist at Baylor Scott and White, the Heart Hospital, Plano. Prosthesis-patient mismatch remains a topic of controversy in patients undergoing TAVI, particularly among women with smaller annuli. We've seen the recent results of the SMART trial comparing a small annuli between balloon-expandable and self-expanding. Although self-expanding valves appear to provide superior hemodynamic performance compared to balloon-expandable, but the impact of PPM severity on long-term survival, particularly regarding sex-specific differences, remains inadequately characterized. This was a retrospective cohort study from a large multi-site center study of 3,000 patients who underwent native valve TAVI from 2012 to 2021. Patients were stratified by sex, valve type, and PPM, whether it was predicted PPM and measured PPM, and the severity was assessed based on the VARC criteria. The primary outcome was all-cause mortality at 5 years, with secondary outcomes including PPM incidence, severity, and residual transvalvular gradients. Women exhibited higher rates of severe predicted PPM and severe measured PPM. Neither moderate nor severe predicted or measured PPM adversely affected the 5-year survival in women. Self-expanding valves, as noted before, were associated with lower overall predicted and measured PPM as compared to balloon-expandable valves. 5-year survival was similar within the PPM strata following risk adjustment. What we have learned from this study is, in fact, men with moderate to severe PPM may have a worse outcome in the long term as compared to women. This could be driven by other factors when risk stratified. Yet, I think the decision of the type of prosthesis and keeping in mind the lifetime management of aortic valve stenosis and multiple therapies as we stage them across the patient's lifetime is key in considering the valve type and when would they be planted, and should TAVI be the first treatment or SAVR. The take-home messages is that despite a larger EOA, despite a higher number in terms of mean gradients, or likely larger number of patients with predicted PPM or measured PPM in the balloon-expandable cohort as compared to self-expandable, yet the survival was not any different between both. This keeps coming up as a very important key finding, is that maybe the valve prostheses have different fingerprints in terms of gradients, in terms of pressure, findings across patients, whether they were male or female, as we have previously published our 5-year outcomes across the whole cohort, similarly also in the valve-in-valve cohort. But more importantly, what we need to focus on is it's not really about which valve may be outperforming the other valve, but perhaps what is best for that patient from an anatomical standpoint, from thinking about coronary access and future coronary interventions, and obviously a future valve-in-valve option for those patients. Further research will include the long-term follow-up for low-risk patients. In this study here, they are mostly intermediate and high-risk patients. We would like to also see long-term outcomes from a quality of life perspective. We have presented our quality of life data previously, and the manuscript will be published soon, with obviously no differences in outcomes, whether someone had severe PPM or no PPM. So there's much more to come on whether patients are requiring re-intervention sooner than later when comparing severe PPM to no PPM patients.